Well, let me welcome you to Medical Grand Rounds for this year, our first Grand Rounds of the year, and we couldn't possibly start off with a better Grand Rounds than with one of our fairly new faculty members for 2 or 3 years. Many of you know Janet Rubin. Those of you who don't, she's a true physician scientist, someone who attends, teaches, has a outstanding research program. We recruited she and Larry from Emory, and they've both been wonderful additions. And Janet offered to give this first Grand Round. She offered to try to tailor it to our audience. And well, she's mouthing that she didn't really offer, but she agreed to. So I think it's a great way to start the year, and I want to thank Janet for coming today.
Thanks, Marshall. I was really conscripted into giving this Grand Rounds. So I'm honored to give the first Rounds of the year, and my goal is to really give you information that's really biologically interesting, that's very clinically relevant, and that I hope will push the way that you think about medicine and think about the things that we don't know in medicine and that are really fun to find out. Because it's something I always need to remind people in the trenches that medicine's really fun. I think most of us are doing it because it's really fun. So it's pretty obvious that I'm going to be talking about bone today, which is the skeleton, which is my favorite subject. But what I want to do is I want to kind of step back and re-enter thinking about bone and get you thinking about bone. So I thought I'd pose a series of questions for you. And the first questions I'm going to ask are a series of questions of what's the difference between the things that I'm showing you here. So remember, we're talking about the skeleton. So I don't really need an answer that the amoeba on the left is a single-celled organism, or that the cheetah on the right has spots. What I'm really looking for is the difference between these is that one has a skeleton. So by virtue of having a skeleton, the cheetah can get out in the bush and run around, see the land, and pounce on impalas. So the skeleton is there to allow large organisms to locomote. What's the difference in this picture? Well, they're both boys. The boy on the left is very active. He's having fun. He's doing fun stuff. He's probably, on his skateboard half of the time. And the boy on the right, who's a little misshapen, doesn't get through the world very well. He doesn't locomote because his skeleton is continually failing. So the boy on the right has osteogenesis imperfecta, and his skeleton doesn't work well. What's the difference between these two really great athletes? And that's a little bit of a harder question. And the answer to the question here, at least in my world, is Beckham, playing soccer, does an exercise that promotes bone formation and increases skeletal strength. And Floyd Landis, who's won the Tour de France and then got his title taken away from him because of a supposed 1 day of testosterone usage, that Floyd Landis participates in a sport that doesn't build bone mass and actually seems to have a skeleton that's maybe a little susceptible to failure. So as we move along, I'm going to try to encourage thinking about mice at the same time that we think about humans, because we've learned a lot from mice. What's the difference between the moose on the left and the mouse on the right? And if you look carefully here, the mouse on the right has a failed skeleton. The mouse on the right has osteoporosis, and we're going to return to this mouse and find out why this mouse has osteoporosis. So in general, we're going to be talking about the skeleton. The skeleton has two classic functions that it subsumes. One is it's a critical site for calcium homeostasis. All endocrine people know that. But it's really its main teleological purpose is to allow locomotion, to allow us to get around and have the lives that we have in the world. When the skeleton fails, both of these functions are at issue. So there are problems with calcium homeostasis and with skeletal structure. Now, to kind of start wrapping my thoughts into little circles that are going to be circling around each other, the mouse skeleton is extremely similar to the human skeleton. In fact, it's a great organism to study if you're a skeletal biologist. Now, that's not true for mouse and other kinds of organs, but it's very true for the skeleton. Not only does the skeleton really look real similar, you know, little scapulae and ischium and femora and tibia and ulnas, but it's formed very similar, and most of the things that we can find that go wrong in the human, we can replay these in mouse. And in the last 15 years, the bone world has learned an enormous amount by studying the mouse skeleton. So I'm going to come back and I'm going to foreshadow what we're going to be talking about by comparing mouse to human, or human to mouse. And the first topic that we're going to cover is skeletal modeling. And skeletal modeling in the lady who has pseudohypoparathyroidism on the left, it's a genetic mutation that causes obesity, short stature, and this curious shortening of the fourth metacarpal or metatarsal bones is completely replayed when this gene is mutated in the mouse. And we're going to talk about this a lot. But the answer to the question of what's the similarity, it's the same gene on the left and on the right that's mutated. And this mutation, if it comes from the mother, besides causing a skeletal phenotype, it also causes hypocalcemia and obesity. The similarity between the mouse and the human here is the gene in question is imprinted, and that gene is G sub alpha, G protein receptor, the G protein that couples with 7-pass receptors, G sub alpha, or often called GNAS, and it's the gene that's implicated in pseudohypoparathyroidism. So this is an example of skeletal modeling that's gone awry. The second subject that we're going to talk about today is skeletal modeling. And in this case, there's a problem with skeletal modeling both in the human on the left and the mouse on the right. And the answer, of course, is that both of these specimens have a problem with bone remodeling that causes osteoporosis. The third subject and last subject that we're going to talk about is how modeling and remodeling is both affected by epigenetic or non-genetic factors. In this case, exercise, and the curious specimen here on the bottom where PPAR gamma, which is a transcription factor in fat cells, one allele is knocked out. There's more bone in the bone and less fat in the bone. That's the same thing that's happening to David Beckham's bones. His bones have more bone and less fat in the marrow cavity. So the similarity between David Beckham and the PPAR heterozygote knockout mouse is that they have less fat in the marrow and more bone. So we're going to have, as I said, 3 subjects. We're going to talk about skeletal modeling, skeletal remodeling, and epigenetic control, in our case, exercise of modeling and remodeling. In each of these times, I'm going to try to talk about physiology, which some of you learned in medical school, and some of you are too old to have learned it in medical school, or you forgot. I'm going to take this physiology and say how it affects what we do clinically, so hopefully you'll learn a few clinical points today. With skeletal modeling, we're going to talk about a little bit about calcium homeostasis. In remodeling, we'll talk about how to treat osteoporosis. And then with each of these, in each of these chapters that I'm going to tell you, I'm going to talk about what are the next steps and what are the frontiers in skeletal research. And obviously, it's not meant to be a talk that covers everything in the skeleton. I'm just covering a little bit of the skeleton. Okay, so we're going to start with Chapter 1, skeletal modeling. Skeletal modeling happens early when in utero. Before 8 weeks, there's a kind of a membranous hyaline skeleton, but by 8 weeks, the bones start ossifying. And bones that are in the pelvis and in the skull ossify by intramembranous ossification. I'm not going to talk about that today, so you're just going to have to put that aside. I'm going to talk about disorders that have to do more with the growth plate or growth of the bone, lengthening of the bone, as in endochondral ossification. And that's how bones in the long bones turn into bone from cartilage. So you start with a cartilage enlarge, or a form of bone. A bone cuff starts to form, again, around 8 weeks in utero. And this cuff is penetrated by some blood vessels, and with those in come osteoblasts, and the bone starts, all these little black things here are bone, cortical bone and trabecular bone here. At the growth plate, the bone continues to elongate because of proliferating chondrocytes. So as long as those chondrocytes can keep proliferating, the bone length will continue to grow, to elongate. And that stops when you go through puberty and the epiphyseal plate closes. So no more bone growth. So most of the bone growth is happening here in the growth plate with these proliferating chondrocytes. So what happens when something goes wrong with that? And we're going to talk about that in terms of pseudohypopara. But the most obvious and the most common form of dwarfism that we see on TV, if you watch Chewy on Chelsea lately, I don't know if people do that. I do. But the most common form of dwarfism is achondrodysplasia. And it's the same in the mouse as in the human. This is a problem with FGF receptor 3. And in this case, in the case of achondrodysplasia, FGF receptor 3 is constitutively on. So obviously that receptor being turned on stops the growth plate, stops the chondrocytes from continuing to proliferate. So here's a wild type. If we just cut into the mouse bone, can't cut into the human bone. And you have these hypertrophic cartilage, or chondrocytes, and proliferating chondrocytes. So the proliferating chondrocytes are pushing the bone and having it grow. When they move away from the growth plate, they become hypertrophic, and those hypertrophic chondrocytes are replaced with osteoblasts and pure calcified bone. You can see here, so you see here the growth plate. This is the growth plate here. This is secondary center of ossification on the other side of the growing bone. In the FGF receptor 3 on mouse, or in the human, what happens is really a disruption of endochondral proliferation. So there's poor proliferation. There's actually no good distinction between the secondary ossification center and the primary one, and there is a problem with the bone. So the bone doesn't grow, and there's really abnormalities in long bones, but not in the axial bones or in the bones that ossify by by membranous ossification. So if we kind of step back and look at this in a more cartoon form, what you have in this growing bone is that at the perichondrium of the bone, or the tip of the bone, these perichondrial cells secrete something that's called PTH-receptor. Now, all people who are doing medicine know that if you have cancer and you secrete PTH-receptor, you get hypercalcemia. And that's because PTH-receptor is very similar to PTH, and it binds to the PTH receptor. PTH-receptor in utero and in embryonic development allows these proliferating chondrocytes to keep proliferating. The farther away these chondrocytes get from where PTH-receptor is being secreted, the more they're going to have a tendency to enter a transition zone and eventually turn into a hypertrophic chondrocyte. Now, the hypertrophic chondrocytes secrete something that we're not going to be very interested in today. It happens to be called Indian hedgehog. It was named after Sonic Hedgehog, so it's actually named after a computer game, believe it or not. But Indian hedgehog feeds back and turns on PTH-receptor and keeps this process going. So if PTH doesn't work, if PTH-receptor doesn't work in the elongating cartilage enlage, then bone growth is going to be abnormal. So there are forms of abnormal bone growth where PTH-receptor is abnormal, but the more common form that we see in endocrine clinics is when PTH doesn't have an adequate function after it binds to its receptor. So while we're learning about PTH, we're also, PTH-receptor, we're also should be thinking about PTH itself, since, as I told you, they both bind to the same receptor. This is PTH-receptor 1. This is a 7-pass membrane receptor that utilizes G proteins, this G sub alpha that I mentioned before, to cause intracellular signaling. So when cyclic AMP gets made, it goes to the gene and causes PTH or PTH-receptor gene expressions. So when the ligand binds to PTH receptor, whether it's PTH or PTH-receptor, what happens is G, which is usually sitting there bound to beta and gamma G proteins, this G protein is recruited to the receptor, and there's all sorts of other things that go on that we're not going to get into today. G beta and gamma go away, and this G sub alpha then recruits adenylate cyclase, and cyclic AMP is made. And PTH and PTH-receptor have most of their functions through cyclic AMP. Now, it turns out that this gene, GNAS, or the GNAS cluster, is an incredibly complex gene. It's a gene that's imprinted. So I didn't learn about imprinting when I was in medical school because I don't think anybody knew about it. I thought imprinting was the little duckies following their duck mother, but that's not what imprinting is when you're in medicine. So to give you the most fun example of imprinting is the idea of the horse-donkey hybrid. So if you mate a horse and a donkey together, you get either a hinny or a mule, which are totally, completely different animals. They're both sterile, so you have to continue to do the mating. But there's a lot of reasons why a hinny who has a donkey mother and a horse father is different than a mule who has a horse mother and a donkey father. Some of it has to do with interuterine development, but a lot of this has to do with imprinted genes that we don't really fully understand. So an imprinted gene is methylated and it's silenced. Each of us have in all our cells an allele from mom and an allele from dad. Some of these alleles function right alongside each other. You know, you have a little bit of dad gene, a little bit of mom gene being expressed. But some genes only work off a paternal or a maternal allele. And there are some diseases in medicine that are caused due to genes that are imprinted. One is Prader-Willi, which is a disease of massive obesity. Beckwith-Wiedemann, which is, has gigantum associated with it, and the gene that we're about to talk about, which is GNAS, which is responsible for pseudohypoparathyroidism. So this is the GNAS locus, and the GNAS locus has 3 genes on it. It has NESP, XLAS, and G sub alpha, which this particular thing from Lee Weinstein is only showing exon 1 and 2. Now, the maternal and paternal alleles for this locus are completely differently imprinted. The paternal NESP is silent. The maternal XLAS is silent. Now, if you ask me what that does, I don't know, because nobody knows what these genes do yet. They are highly expressed in the brain. But the GNAS gene for G sub alpha here is methylated in this exon in the maternal allele and not in the paternal. So what does that mean? It doesn't make any difference if the tissue happens to be driving off both the maternal and paternal allele. But you can see that in this mouse who got the mutated gene, and the mutated gene for this mutation does not make a viable protein. Toggle. So the GNAS gene is not made if you have the mutation. So in the parental, if you get the mutation from the paternal, this is what the little mouse looks like. Here's its litter mate. If you get the mutation from the mother, this is what the newborn looks like. They're both short because GNAS in bone is expressed off the paternal and the maternal alleles, but this mouse has a calcium phenotype, and this one doesn't. You'll also notice that in the mouse, if you get the GNAS mutation from the mother, the mouse is really fat. And the paternal mutation actually brings leanness with it. Now, that's actually different in the mouse than in the human, because if you get a paternal mutation, you're still going to be fat, but not as fat if you get it from the mother. So why does the maternal allele bring with it hypocalcemia of pseudohypopara? Because this gene is imprinted in the renal system. It is only in the kidneys, run off the maternal allele. So here, if the maternal has the mutation, and here's the kid, has the maternal mutation, the paternal allele is imprinted and it's silenced. So if you look in the kidneys, there is no G sub alpha. If you get the imprinted mutation from the paternal side, it doesn't matter that that gene can't make any GNAS because that gene is silenced. So you can see that the mutation in the kidney tubules coming from the father looks like it's normal. So GNAS is expressed in the maternal allele in renal tubules and the thyroid, pituitary, ovaries, and the pseudohypopara phenotype can be very different between families because of the way that it's expressed in these other glands. Now, GNAS, because it is the G protein that binds a lot of 7-pass receptors, can have effects on TSH signaling, ACTH signaling, epinephrine signaling, norepinephrine signaling. So there's a very mixed phenotype in the pseudo-hypoparathyroid. So here's a girl who got the mutation from her mom. She has the skeletal phenotype, and with this in the mom, this is called pseudohypopara. she has hypocalcemia due to PTH resistance at the kidney. She also has massive obesity. The paternal allele is the disease that's called pseudo-hypopara. I remember learning about this in medical school and saying, I can't believe this. It's ridiculous. But pseudo-hypopara is you have the gene, but you don't have the calcium defect, and now you all know why that is. So the effects of GNAS, kind of moving a little bit into what we don't know, and there's a lot we don't know, is that the maternal gene also brings with it super obesity and hypometabolism. Whereas you remember that, and if you get the allele from the father, you're fat, but you're not super fat. This is different in the mouse. The gene here from the father actually causes leanness. Now, we don't know why GNAS causes obesity, and of course, we'd really like to know. GNAS is not imprinted in fat, so it's probably not a direct effect on fat development, and it probably has to do with imprinting in the hypothalamus and eating. So that's something that we have to find out. So clinically, when we think about PTH receptor and how it works, PTH receptor is important in growth of long bones, but it's also important every day when you go into your clinics. If you have hypocalcemia or hypercalcemia, the first thing you have to think about is what is PTH, because PTH is the calcium hormone. It regulates calcium through renal resorption and through bone remodeling, as well as through vitamin D. So we're going to go on to chapter 2 in my little survey here today, and we're going to move from bone modeling into bone remodeling. So you think about bone modeling, that's here while we're growing, the epiphyses close, and all the time, or those of us who are, all of us are adults in the room, I don't think anybody doesn't have their epiphyses closed here, but as we're going along, our bone is always remodeling, and then we get to be fairly old, and don't like to take this personally, but as you start to get older, your bone starts to remodel in not great ways, get a lot of endosteal resorption. Some of this is made up for by modeling in the periosteum, but during all this time, bone is continually adapting and remodeling to the stresses and strains that we put on it. We also have to go back when PTH has goes and gets calcium out of the bone. We have to remodel those bones and make up for the calcium that we took away. When we remodel too much, or we remodel with not enough in the bone formation direction, we get osteoporosis. So this is the clinical part of this. Here's the 20 to 25-year-olds in the audience. You can see bone looks pretty good at 40 years old. This is a woman. 60 years old, postmenopausal. Bone, this is not a disease. It's just a failure of appropriate remodeling with catastrophic failure of bone as we lose the structural integrity of bone. Now, clinically, I like to say to the people who don't think osteoporosis is important in the audience, it's a very important clinical entity. If you add in women all the heart attacks, strokes, and breast cancers together, they do not equal the number of fragility fractures in the population. But I can tell you a heck of a lot more money is spent on these. We could argue about that for a while. But so how does that happen? So what's happening, what goes wrong in osteoporosis? So bone remodeling as well as skeletal modeling is a cellular process. So we've got some nice bone here, osteocytes sitting there giving signals that the bone's healthy or not. And then something happened, some signal. Maybe PTH was around. And what happens at this point is cells of hematopoietic origin, these multinucleated osteoclasts, are recruited to the bone where the signal is and create a lacunae, a Howship's lacunae. This lacunae sends out a coupled signal that recruits osteoblasts. We'll talk about that a little later. And these osteoblasts make new bone. So bone is continually turning over. So what happens in osteoporosis. So in osteoporosis here, I'm showing you the Dowager's hump and this crust fracture in a thoracic vertebrae. What you have is too much bone resorption and too little bone formation for many reasons. So one of the things we might ask is, how are osteoclasts recruited and how are they turned on? And this is one of the things that we point our clinical armamentarium at. And the way we learned about this was in 1997, two labs published these series of experiments at the same time. We learned totally through the mouse. So we couldn't figure this out just doing human studies. And this series of work started with the discovery of a protein called osteoprotogerin. Osteoprotogerin is a soluble receptor for a ligand of the TNF family that we'll find out what that is in a second. Now, it was a great protein to discover. It doesn't have an effect itself. It just circulates around. It doesn't hook up to any intracellular signaling. But it's a good thing to study with a gene because you can just dash it off into the circulation and see what it does. And this is what Simone and his group at Amgen did. So here's a normal mouse skeleton. They took osteoprotogerin, they said, we don't know what this thing does, hooked it up to an apolipoprotein E receptor, so the liver made huge amounts of this protein. And in the overexpressing mouse, what you can see, and this is a mouse that was selected because it expresses OPG, but not a lot of OPG, what you start to see, and they were surprised because they didn't know that it was going to do this, that the bone looks like there's more bone there. It's more dense. And in the high, if you pick a transgenic that has a very high level of OPG expression, you can see the bones are actually osteopetrotic. They've really totally ablated the marrow because turns out there are no osteoclasts or less osteoclasts there to maintain the marrow and keep bone remodeling going in the right way. Now, this turns out to be a reason for a disease that's a really horrendous disease, which is really misnamed Juvenile Paget's disease. And in Juvenile Paget's, there's a complete absence of OPG. The mutation in this gene completely wipes out OPG. It's different than adult Paget's, which we all argue about what it is, but there's no osteoclast intranuclear lesions. This disease is an autosomal recessive, and these patients don't have osteoprotogerin blocking whatever it's blocking, which is this little thing here. And because of that, because of no OPG, lots and lots of osteoclasts. This is exactly true in a mouse where you knock out OPG. And you can see here a normal mouse, you start to get used to looking at these bones. Here's an early mouse. You can see that it has very little cortical margin. And later on, a couple weeks later, down the road, that mouse has catastrophic failure of its bones and really pretty significant osteoporosis. And you'll remember I showed you this before. So the question quickly followed, what's the ligand for that receptor? And the ligand for that receptor was called all sorts of things at first. Obviously, one of the names for it was OPG ligand, but is now known as rank ligand, so receptor activator of nuclear kappa B ligand. And this ligand is almost exclusively expressed on bone cells or bone-forming cells, and sometimes on leukocytes in rheumatoid arthritis. So if you knock out rank ligand, which I'm intimating allows osteoclast recruitment, what you get is a runted mouse. And one of the reasons that mouse is runted, not only can its bone not remodel, but the mouse can't eat because its teeth can't break through the bones of the jaw. So you have to have osteoclast to have your teeth erupt. So Anytime you see a mouse that the teeth aren't coming out, it's likely that they have a problem with osteoclast. And in the rank ligand knockout mouse, no teeth coming out. Here's the incisors, and no teeth coming out here, you can see. And this bone, which is totally osteopetrotic, and a rugger Jersey spine. So rank ligand expressed by cells in bone is the ligand that recruits osteoclasts during bone modeling and during bone remodeling. And rank ligand is turned on by things like parathyroid hormone. So we use this bone remodeling to think about how we treat this very significant condition of osteoporosis. Most of the drugs that we use are drugs that are anti-resorptives, or actually directed and targeted exactly to osteoclasts. And those are the bisphosphonates. Estrogen also turns off osteoclasts. Denosumab is on its way. It should be FDA approved probably by the end of the year. It's a humanized monoclonal antibody against rank ligand. The anabolics, which we'd like to have a lot more of, we'd like to make bone form, not just keep it from being resorbed. The only anabolic we have on formulary in the U.S. is Forteo or teriparatide. There are some things that are going to act like PTH. Strontium is in use in Europe, is probably an anabolic, and anti-sclerostin is being studied. Now, I bring up anti-sclerostin just because I'm going to come back to it. So just quickly, using these kind of drugs, you can hugely improve osteoporosis. You can prevent fractures. This is a use of alendronate or Fosamax. Hip and vertebral fractures, it's a great drug. It should be used more. Obviously, if you give this drug to a 50-year-old woman, it's not going to have this effect because 50-year-old women don't fracture. So this is a data that looks great because you're using it in a fracturing population. PTH also works well. It causes bone formation, as you can see over here in this human micro-CT on a patient treated with PTH. You get cortical increase in the cortical margin of this iliac biopsy, as well as increase in trabecular structure. So I told you that we'd like to be able to tell osteoblasts to make new bone. So we're moving into the last part of this talk here. And one of the things we have to understand about osteoblasts is where they come from. And we really learned a lot about this when people figured out what autosomal dominant osteopetrosis was. And remember, I've been showing you pictures of osteopetrosis. And largely, we've thought of osteopetrosis as a disease where osteoclasts don't work. In this case of ADO, which is a subclinical disease, this is a disease that happens because too many osteoblasts are making too much bone. You can see here these wide cortical margins and almost a rugger Jersey spine. This turns out to be a mutation of a receptor that's called LRP5, or lipoprotein-like receptor 5, which is constitutively on. This receptor activates beta-catenin in precursor cells for osteoblasts. A horrible disease where LRP doesn't work, where it cannot be turned on, is osteoporosis pseudoglioma syndrome. It's the same in a mouse. I could have showed you a mouse. But it causes failure of bones along with some other things that have to do with LRP. Very, very thin bones that can't support any weight at all. So in this condition, we're talking about where do osteoblasts that form bone come from? So we have to go back to the whole remodeling thing and think about what kinds of cells are there. So we'd like to be able to treat bone fragility by turning on these cells. Well, they come from not the same lineage as the osteoclasts. They come from a mesenchymal stem cell that can become all sorts of things. One of the things that it can become, if there's enough Wnt and beta-catenin signal around, they can move into the osteoblast lineage and create bone. If they don't move into this lineage, almost default, or certainly an age-related signal, is these mesenchymal stem cells will move into a fat lineage. Here's a cell full of little fat droplets. So it turns out that there seems to be some selection between these cells becoming fat cells or becoming bone cells. And we really learned this in a beautiful paper published in JCI by Akuni's Japanese group in 2004 with this mouse, which is the PPAR gamma heterozygote knockout. So PPAR gamma is a transcription factor that is absolutely required for fat cells to form. And they form from those mesenchymal stem cells, and they turn into fat cells when PPAR gamma is ligated and turned on. Now, if you cut out both PPAR alleles, or get rid of both genes, it's lethal. So they did it here as a heterozygote. And this mouse has more bone and less fat in its marrow. By the way, lipodystrophy is associated, some of the types of lipodystrophy are due to abnormalities in PPAR gamma transcription factor. So this led to a lot of thinking about what PPAR gamma and what fat cell development has to do with bone. And at this time, all of us in diabetes were using these PPAR gamma agonists, and we still are, that are called thiazolidine diones. These are in wide use to treat diabetes by stimulating PPAR gamma, the PPAR gamma receptor. In mice, PPAR agonists cause a profound decrease in trabecular and cortical bone. So we started to worry that maybe these TZDs that were in wide use were going to cause problems, clinical problems in diabetics. And indeed, they are associated with decreased bone turnover and accelerated bone loss. And there are increased fractures in women with type 2 diabetes who are on TZDs. So if we step back from that and we think, really, what are we talking about here? If we look at our marrow cavities, like remember I showed you David Beckham as an example. When we're young, or when mice are young, your bone marrow cavities, if you pull out the marrow, it tends to be red. If you pull out an old mouse's, and an old mouse is 3 or 4 months old, 5 months old, the marrow becomes yellow. So you have a yellow marrow because it's filled with fat. So as you get older, you convert from red to yellow marrow. And lots of things that injure the marrow cause a conversion from red marrow to yellow marrow. So if we go back to that high bone mass phenotype that I showed you, the LRP on mutation, where beta-catenin is turned on in mesenchymal stem cells and in osteoblast progenitors, what you have is an increase in bone volume in these mice. So they made the same mutation in mice. The green stuff here is bone. And what you also see in that bone is a huge decrease in the fat. And this is an older mouse with lots of fat in the marrow. So fat replaces bone, or bone replaces fat. So that has led to a kind of a change in the field of, instead of thinking about osteoporosis in terms of how many osteoclasts and how many osteoblasts are around, to a shift in our thinking that maybe bone has to do more with how many mesenchymal progenitors we're recruiting into the osteoblast lineage or keeping from becoming adipocytes. So these things happen, alteration in marrow fat with aging, estrogen deficiency, and exercise. Exercise decreases fat in marrow. And this is shown in this experiment done by a French group. They ran rats, in this case, not mice. And you can see that if you run rats, you get a lot more bone formation. And if you look at the marrow, you get a lot less adipocytes in the marrow. So we in my laboratory, so this is my plug for what we do, we thought, how does exercise really affect these cells? So we look at the mesenchymal stem cell that become an adipocyte or an osteoblast, also can become a chondrocyte or a myocyte, but I don't work on that, so I'm not going to talk about it, and ask what could be going on when we exercise these cells. So we exercise them in vivo by taking these mesenchymal stromal cells, plating them in a dish where we can exercise them. So we exercise them for a few hours every day in a media that makes them turn into fat cells. So you can see here the control cells are expressing these lipid globules, and by 5 days, almost all the cells in culture are fat cells. But if we exercise these cells a little every day, lots less of them turn into fat cells. Now, I'm not going to take you through this Western blot, which Marshall said I couldn't show you Western blots, but I just had to. So I'm going to ignore this one to make it easy for you. If we take these mesenchymal stem cells and we put them in this fat media, this adipocyte media, we turn on some things you guys know about. We turn on PPAR gamma. We turn on this fat adiponectin, and we decrease, compare here to here, the amount of beta-catenin is around. If I exercise those cells, I turn on beta-catenin, and I reduce the amount of cells that are expressing PPAR and adiponectin. And I'm not going to tell you about this because Marshall doesn't want me to. So these cells are less fatty when they have this direct exercising in culture. Is this because of beta-catenin? And what we can do in the lab is we can get rid of beta-catenin by targeting an RNA against the catenin gene. So we get rid of catenin. And what I want you to see here, again, if I exercise the cells, more beta-catenin around, less adiponectin, less PPAR. But when CAT isn't there, or a lot of the beta-catenin is gone, the cells, you see the catenin is down, that the cells are much more immune to exercising. So they don't listen to the exercise signal, which is transmitted through beta-catenin. So as we move a little farther past my Western blots, we think about fat in general. There's lots of questions that come up, like why do young people respond to exercise better than old people? But really we have to ask ourselves, are fat cells themselves, we know if we go out and run, we're going to be thinner than if we don't run, and most people think about that totally as being something that has to do with how many calories you burn. But our experiments and other people's experiments in the field suggest that maybe there's more going on than just calories. So to give you an example, and kind of to keep in the bone line, Clint Rubin's lab has kind of transmuted exercising signals into a different form. That's what engineers do. And they deliver this exercise signal through a plate. And they did it here in Colorado to some sheep. And sheep who got the signal in their back legs have lots and lots of bone there. And this is true for kids and ladies and mice. So what happens, and it's hard to look at sheep, these are long-term experiments, what happens when you deliver this rapid, very, very low humming signal to mice in a cage? Well, for one thing, they have more bone. So I showed you that in sheep, so I'm not going to show you that. We've been shown that the same signal, just one more blot, also does all the same things that exercising our plate does. So if we vibrate these cells, we get less adiponectin, less PPAR. But this signal, interestingly, also seems to be associated with decreased fat. Now, Clint Rubin and I argue about why this happens, but in growing mice who are having their bone grow because of this, or their bone increase in density because of this signal, also happen to have less abdominal fat. That's very significant. They also have less hepatic fat if they're on a high-fat diet, and other people are reproducing this work. So the question is out there is is the exercise signal, is there a direct effect on cells that are comprising fat in non-marrow locations? So we're just about finished here. There's lots of questions in this last bit, which is where my personal research interests are. What kinds of exercise are most beneficial, and can we mimic those kind of exercises with different signals in people who can't exercise? Does nutrition, does eating a high-fat diet trump the signals that we have? And clearly they do. If you're anorectic and you run all the time, you're still going to have fat in your marrow. So where do those signals intersect? And the question that Clint and I argue about the most is the fat that's around our middles related to the fat that's in our bone marrow that makes bone? And those are questions that we don't know the answer to. So in finishing up, we started from the skeleton and the critical functions that it performs. We've reminded ourselves about growth of long bones and things that happen in bone that alter that. With that, we've talked about how PTH works through its receptor as well as PTH-receptor, and that receptor utilizes GNAS, which is an imprinted gene. We've moved from that to thinking about how the same cellular functions occur in adult, and when these cells are either there's not enough osteoblasts or too many osteoclasts, that we can have osteoporosis. And I've ended up with really what a lot of us think are really the great frontiers in bone biology, which is trying to think how cells decide to become osteoblasts or become fat cells, and what this means for aging. Before I answer any questions, the little bit of work that I showed you from my lab and my career is supported both by the NIH and by Marshall, who directly transfers money into my bank account. My laboratory, some of whom are here today and are unbelievable, Bohr and Hui are doing most of our fat exercise work. Natasha Case has been responsible for a lot of the Katina work in the lab. Maya Steiner, who was a resident here, is now an endocrine fellow, is working on some very interesting things about fat and COX-2, and Minshaz Zhu also in the lab. And Clint, who's actually my brother, who is my greatest arguing opponent. We spent a lot of time on the phone. So thanks for letting me give grand rounds. I'm happy to answer questions.
We have time for a few questions, and then, as you need to go ahead and you can come up and ask questions. I have a question I want to ask while other people are thinking about it, and that is, with drugs like bisphosphonates, although I know the fracture rates are less, the bone doesn't look quite the same. Does that have anything to do with biology of fat in the marrow, or is that entirely a separate topic? And what is the quality of the bone in bisphosphonate with that general approach of decreasing metabolism?
So, I mean, clearly the bisphosphonates aren't bad because they prevent fractures. The bone is different. You're probably referring to the fact that there's supernucleated osteoclasts that have been found. No one knows if that makes any difference. We're very surprised to find out that bone heals well after fractures. Remember when the drug came out in the 90s, we were worried about that. The bone is probably different, which is why a lot of us are going to these holidays of drugs. There's an unusual fracture that seems to come out after many years being on bisphosphonates, which is a shaft fracture. There's this weird thing in the, in the face, which is a very different kind of bone formation with osteonecrosis of the jaw that seems to be affected by bisphosphonates. But in general, the bone's really good, and most of us are not going to stop using bisphosphonates because of that. As far as I know, we don't know yet that there's a bisphosphonate hit on mesenchymal stem cells.
And how do you decide whether to use PTH or when you should use PTH versus bisphosphonate?
Okay, so I'm supposed to come back and give that talk in December. I haven't written it yet. I usually save PTH for people who are really horrible. Either they have failure by the time they get to me, so they've had multiple fragility fractures, and then I just give them the biggest, baddest drug I can give them, or they have an extraordinarily low T-score, and I might determine to give it to them. It's a little bit of a problematic drug, so it's not, you know, for the usual osteoporotic, I don't use it. You know, I probably use it less than other people. It has a very wide therapeutic margin. Some people it works really great, and other people it doesn't work great. So, and you can only use it for 2 years, and most of my patients always want to go off even before 2 years. They just don't like using it. Yeah. So I'm not, you know, not wholly against hormone replacement. I think, you know, that the Women's Health Initiative was a study where women who had been in menopause for a while were put back on it. So I think lots of doctors' wives, at least in our community, went on estrogen and stayed on estrogen. They say, oh, I'm not coming off. I don't have a problem with that as long as you see your gynecologist. I'm not going to manage your pap smears and whatever. So that's problematic. I think the drug that I am more interested in using than I used to use, and there is a risk of, you know, increased endometrial cancer and increased breast cancer in people who are on estrogen. That is still there. And I don't want to be the person who, you know, they look at me, they think I'm responsible for their breast cancer. The drug that I am starting to use a little more is an estrogen-like compound called raloxifene, which is a kind of a delightful little compound. Not only does it prevent fractures, but it also gets a secondary hit of it seems to decrease breast cancer. So is it the best drug for osteoporosis? Probably not, but a lot of women don't want to take bisphosphonates for whatever reason. Is it a good drug? Yes. One of the other things is, and this is kind of a little bit has to do with Americans, is they like to see improvements in their bone mineral density, even though it doesn't really mean much. And the estrogens and estrogen-like compounds don't cause as much improvement in bone mineral density as the bisphosphonates or PTH do. It's hard to argue back with them. I try to tell my patients, don't look for a big improvement in your bone mineral density. So I hope that's an answer.
Let me take Janet